Okay, I think let's get started. Welcome, everyone. My name is Catherine Chu, and I'm the director for the Center for Global Surgery at Stellenbosch University in South Africa. And it gives me great pleasure to welcome you all on behalf of my co-speakers. Could I just ask everybody to mute themselves? I think I hear a little bit of a background noise, and that would be great. So just to give you a bit of overview of the program, we're going to start off talking about the epidemiology of road traffic crashes and a bit of the burden of disease to set the scene. We're going to talk about various risk factors, both alcohol and non-alcohol. We're going to talk about road safety models and why they matter. We're going to talk about road safety attitudes globally. We're going to touch on the WHO Global Report on Road Safety and its data collection.
Recording in progress. I'm really excited to hand the microphone over to my colleagues here today, Marco De Loca and later Janelle Jett, who are
Jenna, we seem to have somebody else in the background that's not muted. Thanks. Then we're going to conclude with talking about global health equity and solutions around road traffic crashes, and then finally have time for hopefully a lively discussion. Maybe just a few housekeeping rules. If you can keep yourself on mute during the presentations. We've got a great panel of speakers, some live and some pre-recorded. We will try to hold the questions for the end, but if you have questions for the live speakers that are burning, you can type them in the chat, and then we can see if we've got time during the presentations or just after their presentations to address a couple of questions around clarity. Otherwise, we will get to the questions at the end. Okay, without further ado, let's get started. So first, I wanted to touch on the epidemiology of injury for road traffic crashes. So let me just start with a few definitions. So a road traffic crash is defined as a collision or an incident that may or may not lead to injury occurring on a public road involving at least one moving vehicle. And road safety pertains to the measures taken to reduce the risk of road traffic injuries and death. So what is the burden globally of road traffic crashes? Well, pretty high, 1.35 million deaths around the world and 50 million injuries. And more than half of those deaths are from the vulnerable road users, like the pedestrians, the cyclists, and the motorcyclists. And road traffic crashes cost most countries 3% of their gross domestic product. So very high impact. This map on the upper left shows a map of the world distorted by gross domestic product or the wealth of a country. So you see certain countries like North America, certain continents like North America, Western Europe, and Japan are extremely overrepresented, but other continents don't exist. But let's contrast that with the trauma burden, including road traffic crashes, and you see a very different picture. Other continents like Africa, where Heike, Richard, and I live, are extremely dominant, and those wealthy countries are almost non-existent. So road traffic crashes and trauma are inequitably distributed around the world. And really the disproportionate amount is in low and middle income countries. But the rate of road traffic deaths around the world is certainly also very different. And here in Africa, we have the leading mortality rate from road traffic crashes with the highest, and contrast that with the Americas and Europe, who have the lowest. But even within a high income country, there are inequities. So the poor in high income countries still have higher death rates from road traffic crashes. And the most vulnerable are our young people. In the BBC headlines, road accidents, biggest killer of young people. They are the leading cause of death for children and young adults, aged 5 to 29. And 70% of all road traffic deaths occur among young males under the age of 25, who are almost 3 times as likely to be killed compared to young females. And this situation overall is worsening. So in 2004, road traffic crashes were the 9th leading cause of death, but by 2030, we expect that to jump up to 5. So what are we doing about this? Well, the WHO response so far is 3-pronged. WHO offers technical support to countries. They're the lead agency in an initiative called the Decade of Action for Road Safety, Initially, it was 2011 to 2020. Now there's another one, 2021 to 30, and I'll touch on this. And they're monitoring progress through global status reports of 197 countries. So the WHO was the lead, or is the lead organizing agency for an initiative which was initially termed Decade of Action for Road Safety, 2011 to 2020. And the overall goal was to save millions of lives by stabilizing and then reducing road traffic deaths around the world. And there was a 5-pronged approach, and that I'll mention is road safety management, safer roads and mobility, safer vehicles, safer road users, and a better post-crash response. So for road safety management, this includes strengthening institutional capacity, putting in practice the UN Road Safety Conventions, establishing a lead agency, developing national road safety strategies, setting targets, and then developing data collection systems. The second pillar, safer roads and mobility, includes improving safety conscious planning, design and construction, operation of roads, assessing regularly the safety of roads, and exploring various forms of transport and safe infrastructure. The third prong or pillar is safer vehicles, harmonizing global standards, implementing new car assessment programs, equipping all new cars with minimum safety features, and promote use of crash avoidance technologies, and encourage managers of fleets to purchase, operate, and maintain safer vehicles. For the road users, to make them more safe, adopt models of road safety legislation, sustain or increase enforcement, promote public awareness of risk factors, call for activities to reduce work-related road traffic crashes, establish graduated driver licensing programs for novice drivers. Some of our other speakers will speak about this, but better legislation really does work. And it's quite important that a country enforces those laws. Otherwise, they won't be followed. And then the last is the post-crash response. So as clinicians, this affects us getting better pre-hospital care systems, to have one single emergency telephone number to be able to phone, provide early rehabilitation and support to injured patients and those bereaved by road traffic crashes, to have insurance schemes, national or private, to pay for injured persons and investigate crashes and provide a prompt legal response. This initial decade of action has now morphed into the next decade. Last year, there was sort of an announcement on World Safety Day for the next phase of this, and the goal is to have road traffic deaths by 2030. I'll stop there in terms of the policies. This was just the bird's eye view, and hopefully we'll definitely have time to discuss this more as we go along. For the next presentation I'd like to share is behavioral risk factors. This is a presentation by Judy Fleiter from the Global Road Safety Partnership. She lives in Australia, so her presentation has been pre-recorded because it's the middle of the night there.
Greetings, colleagues. My name is Judy Fleiter. I represent the Global Road Safety Partnership, a hosted program of the International Federation of Red Cross and Red Crescent Societies, and it's a great pleasure to be with you today. I'd like to thank the consortium organisers for inviting me to make a presentation to you today. I've been asked to speak with you today about behavioural risk factors for road traffic crashes. And so in this session, I'll be covering speeding,
I'm sorry, someone said that they can't see the video. Is that still true?
Yes, Catherine.
Okay, sorry about that. Let me try that one more time. Apologies for that. I'm just going to rewind to the beginning of the talk.
factors for road traffic
now?
crashes. And so in this
Good.
session, I'll be covering speeding,
thanks.
impairment, including drug use and distracted driving, but not including impairment from alcohol, as one of the other speakers will cover that topic. And I'll also be talking about the non-use of helmets and restraints. So let's start with speeding. Why is it that this is such an issue, and why is it that people are prone to this behaviour? Well, there are a range of reasons. I'm sure you can think of many. We get an instant reward from driving or riding fast. We seem to have a need to overtake those in front of us. We have pleasure from driving fast, and it's part of seeking of sensation on the road. It's a great way to meet that need for those who are high on sensation-seeking scales. We also have varying perceptions of risk. We're not very good at judging risk of harm to ourselves, but we do have perceptions about risk of being caught by police or authorities when we're doing the wrong thing, and often they're misperceptions. And also our risk of understanding personal harm is not always accurate. Another reason we may speed is because vehicle advertising can promote high speeds, and that can be despite codes of practice related to advertising of vehicles in particular. And also the design of some vehicles, and you can see a photograph there, an image of a speedometer, can actually promote the concept of driving faster than the posted speed limit. You can see that the middle speed on that speedometer is 130 kilometres, which is likely to be much faster than a nominated top speed. So why is this a problem? Well, speeding is linked both to your risk of being involved in a crash, as well as the severity of the outcome of that crash. Speeding increases the likelihood of being in a crash. The distance travelled during your reaction time increases as your travel speed increases, and the distance needed to stop also increases. And in a crash, the greater the speed, the greater risk of serious injury or death. In other words, the severity of the outcome of that crash. And this is particularly true for vulnerable groups, vulnerable road users, those who are not well protected by a metal shell of a vehicle, our pedestrians, our bicyclists, our motorcyclists, for example. This graph shows three risk curves, risk of a fatality at different speeds. And you can see that the fatality risk proportion increases the higher the speed of impact. And the first curve is for pedestrians or cyclists, and the next two are for side and frontal impact of a vehicle. Irrespective of what might cause a crash, it's important to remember that speed is a factor relating to the outcome of every single crash, because it has direct relevance to the physical forces that are applied to the human body when things collide. And so no matter how good a driver or rider we think we might be, we can't change the laws of physics, and we cannot change what happens to our frail body structures when impact forces are applied in a collision. So it's a problem because it affects a range of driving functions as speeds increase. We've already discussed braking distance. We can have a loss of friction between the vehicle tyres and the road, loss of stability of the vehicle, less time to notice and react to hazards, and other people using the road might misjudge the speed at which we're travelling. And the evidence tells us that a small reduction in average speed, so a 5% reduction in average speeds can result in a 30% reduction in the number of fatal crashes. Moving on to impairment, as I mentioned, I won't be discussing alcohol, as another speaker will be, but looking at other substances, prescription medications, illicit drugs, including psychoactive substances, but also we're going to be talking about impairment caused by being distracted. But starting off with drugs, psychoactive drugs impair a range of our cognitions, our functions, and our emotions. Unfortunately, managing drugs and road use is not as clear-cut as alcohol and road use, primarily because it's not as clear-cut, so to say, as how we understand how alcohol impairs the body. And the crash risk of drug use varies depending on which drug substance we're talking about. But a general rule of publication from the World Health Organization some years ago indicated that between 8 and 33% of all fatally injured drivers had consumed a psychoactive drug, and that many of those were in combination with alcohol. Noting here, of course, many countries do not have drug driving laws and do not automatically test drivers who have been killed in a crash. So it's likely to be an underreported figure, I suggest. And an example of a screening study that was conducted in South Africa approximately 10 years ago, and one of the speakers today, I believe, is one of the authors of this screening study. It wasn't a widespread prevalence study, but just to give you an idea, of 269 drivers that were screened, 28% alcohol positive, 14% drug positive, and 5% for both. And you can see listed there the major drugs that were common. And this would be different for every country, but I think it's important to recognise the mixture of drugs that are circulating in communities will certainly have an impact on road trauma. Moving now to distraction, I like to classify that, and you'll see in the literature 4 main issues to do with distraction. Visual distraction, things that take our eyes off the road. So if we're looking for directions, we're checking on people in the vehicle with us. Auditory distraction are things that mask important sounds and feedback that we need to use the road safely. Cognitive distraction is us as road users thinking about other things apart from the task at hand. And physical distraction is tasks that take our attention away from the driving task. We're eating, we're applying makeup, we're reading a map. All of those kinds of things lead to us being not fully focused on the driving task. And here's some data, just one study from the United States, the National Highway Traffic Safety Administration from 2019. This is about young drivers, people aged 15 to 20 involved in fatal crashes. It was indicated that 9% were distracted at the time of a crash. Of course, this information is being presented to you in relation to drivers, also relates to riders of powered 2- and 3-wheelers, but it's also very relevant to pedestrians, people who are impaired by drugs or alcohol for that matter, or who are distracted when using the road. It's not just about people who are in control of a vehicle. And now moving to a category of risk factors that doesn't relate directly to being involved in a crash, but these relate to the crash outcome and how severe that might be. So the first one is non-use of helmets. Why are we focused on helmet wearing? Well, head injuries are a leading cause of death and major trauma for people who use 2- and 3-wheeled motor vehicles. Injuries to the head and neck result in death, severe injury, and disability. And the use of these powered 2- and 3-wheelers is increasingly common. Their users are less protected than those in a vehicle, and there is often amongst the community a lack of awareness about why and how helmets can save lives. So an image here with many powered 2-wheeler riders at the front of a 4-wheeler fleet, exposed to greater danger because of a lack of protection from those impact forces. And sadly, this group accounts for more than half of all road deaths across the world. The brain injury is the big issue here. Direct contact is one result, or rapid acceleration or deceleration is the other cause, the injury mechanism. And so this can result in open wounds, a fractured skull, or closed wounds where the brain is cushioned backwards and forwards against the skull. So the helmet works to add an additional layer of protection around the skull, reduces that deceleration, spreads the impact forces over a greater surface, and it prevents direct contact with the head and skull from objects that it may collide with. And a reminder that helmets can't work properly if they're of poor quality or if they're not buckled and worn properly, and that in itself is a very big issue. And finally, non-use of occupant restraints. So here we're talking about seat belts and child restraints. And just a reminder of what happens in a vehicle crash. The first impact is the vehicle hits something. The second impact is if you're not restrained as an occupant, you collide with the interior of the vehicle. And the third impact is when your internal organs bump up against your body, your skeleton, or your brain bumps up against the skull. So the car occupant without a seatbelt will continue to move at the same speed at which the vehicle was travelling before the collision. The occupant will be catapulted forward, likely to hit the steering wheel or the seats. If not properly restrained, the occupants can be ejected from the vehicle, and that will drastically increase sustaining severe injuries or being killed. And so the seatbelts are designed to help us withstand the force of the collision and spread that force across the chest and the ribs, the sternum and the pelvis, and good protection there for our organs. And effectiveness, a newly released occupant restraint manual that you can see there on the screen. Wearing a seatbelt reduces the risk of fatal injury by up to 50% if you're in the front seat and up to 25% if you're in the rear seat. And finally, child restraint systems. So these are restraint systems designed particularly for our young ones as they grow. They're designed to distribute crash forces over the strongest parts of the body and to be aligned with the developmental stages as the child grows to accommodate their size and their weight. And if they're used appropriately and correctly fitted, they can lead to at least 60% fewer deaths among children. Thank you very much for the opportunity to contribute to the virtual satellite session. I wish you well for the rest of the session. Thank you.
Wow, that was a great talk. It just makes me think how different countries have a very different child restraint laws. Here in South Africa, they're still very common to see small children unbuckled, not in any car seat, and sometimes even in the front seat. And I remember I grew up in the US, and that was still commonplace in the 1970s, but nowadays you almost would never see that. And there would be pretty harsh punishments for drivers if they were caught like that. So just to compare and contrast a bit different country laws. Our next speaker, it gives me great pleasure to present to you Dr. Richard Mostopoulos from the South African Medical Research Council. He's one of South Africa's leading experts on trauma, and he's going to speak to us today about alcohol and trauma and road traffic crashes. Richard, go ahead.
Thank you very much, Catherine, and greetings to everyone. Apologies for scrambling a little bit. I've just got a message that my headset is low, so I'm just trying to make sure that I have a power backup in case it happens again. But so far, so good. So just want to make sure that I am screen sharing. Can you see my presentation yet?
Not yet, Richard.
Okay, let's try that.
We can. It's not full screen yet, but it's up.
Okay, getting there. How is that?
And
I have to
swap displays again.
Okay.
Perfect. I think still swap display.
I've lost my swap display button again.
You're very close to it.
Here we go.
I think it might be. Yeah, there you go.
There we go. Thank
Perfect.
you.
All right.
Great. Thanks very much. Okay, so I'm going to be talking about alcohol and traffic crashes, but a lot of the presentation is about alcohol because it's a major cross-cutting risk factor for a range of diseases. So I'm going to have a bit of a deep dive into alcohol from a public health perspective. I'm based at the University of Cape Town and the South African Medical Research Council in South Africa. And so a lot of my presentation is going to draw on local data. Right. So essentially there are four aspects I'll be covering: understanding the burden on health caused by heavy drinking, understanding the prominence of alcohol as a risk factor for road traffic crashes specifically. Then let's look at how to reduce alcohol harm. And then for a little while, I want to reflect on the status of some of the alcohol harm reduction policies. And all of these I'm going to try and link in with road traffic crashes as far as possible. So the first question is how much we drink in South Africa. And This is a major contributor to the disease pattern, as I'll explain in detail in a little while. But just to show you that there are a couple of features, it's about the pattern of drinking rather than how much. So if we look at the percentage of current drinkers, South Africa is in fact below the global average, which is 43%. We're at 31%, which also puts us below the sub-Saharan African average. But where things get a little bit problematic is when we look at the adult per capita consumption amongst drinkers. And there you can see that of the people that drink, we drink about double the rate of the global average. And this is what we call a heavy episodic drinking pattern, people that drink a large amount of alcohol in a single sitting. And this is a particular risk for injury events. So the question then is, how does alcohol affect health? I'm sorry, I'm just struggling a little bit with navigation. It's not working with my keystrokes. I'm gonna have to use my mouse. Okay, sorry about this. All right, so how does alcohol affect health? So what we need to know is that there are more than 100 different conditions associated with alcohol use. And in South Africa, alcohol is one of the leading risk factors, responsible for about 37,000 deaths, or 7% of all deaths in the country, which ranks it as the fourth or fifth leading risk factor, depending on which metric that you use. Now, a lot of different conditions, and here are many of them, are associated purely with using alcohol. These are 100% attributable to alcohol use, but there are many more that are partially attributable. So there's alcohol explains some of the disease pattern rather than others, and we make a distinction between two in terms of calibrating that risk. And I've checked with the course conveners. There's no ways that you're going to be tested on any of these equations. I just want to point out the two different methods that we use, one for chronic conditions and the other for acute conditions or injuries. And so road injuries would be included in the group on the right. And there are essentially three different exposures of interest for alcohol. So the one is the prevalence of the current drinkers. The second is the amount they consume on average. But a more important one, particularly for these acute conditions like injuries, is the prevalence of binge drinkers. How many people drink at harmful, heavy episodic, with a heavy episodic pattern? And we've already pointed out that in South Africa, it's very common. In terms of how we calibrate the risk, you can see on the left are non-binge drinkers, people that drink according to a normal pattern. And then you can see for binge drinkers how the risk dramatically increases. There's a step function in the risk, and so they're immediate at a much higher level of risk. And we apply these proportions at a population level to work out an alcohol attributable burden for deaths and for injuries and other health conditions. You can see that unintentional injuries, the pie on the left, the segment of the pie on the left account for about 16%. And this is where we have road traffic injuries. But it's important to note that they constitute actually quite a small proportion of injuries of disease overall. What happened during the lockdown in South Africa was quite interesting. The government imposed alcohol sales bans as part of their lockdown strategies. And these are indicated in this chart with the red bands. And what we're looking at, the dark line is essentially the number of non-natural deaths or injury-related deaths occurring on a weekly basis. They've been plotted against what we would have expected, which is that the dotted tracks which has a 95% confidence interval around a darker dotted track. And you can see when alcohol sales bans are implemented, the bits shaded in red, you see an immediate and significant drop in injury deaths, which is quite fascinating from a public health perspective, because it clearly shows the dramatic and immediate effect of removing alcohol at a population level. So we thought that this would be a critical moment in terms of setting alcohol policy. We were mistaken with that belief, but I still think very clear indication and an interesting one for us to take into account as public health professionals. So the question then is, how does alcohol affect behavior? Well, there are a number of mechanisms. I think the previous presenter went through some of those in detail for other for the use of other drugs. Many of them apply for alcohol as well. Alcohol makes you emotional, it lowers your inhibitions. You make irrational decisions and increase your risk taking. And ultimately as well, alcohol is going to make you vulnerable. And all of these aspects have been very carefully calibrated in terms of driving behavior, as the previous presenter pointed out. And we can actually see how these different effects, the effects on the body at different levels of consumption, would translate into impairing driving. So we can see at 0.1 to 0.05 grams, increase in heart and respiration rates, mild sense of elation, relaxation, and pleasure, but that's not necessarily going to compromise your ability to drive. For men, let's say weighing about 80 kilograms, that level would equate to about 2 standard drinks. For women, they would an adult woman of about 73 kilograms would be starting to approach a level where they would not be legally allowed to drive. And you can see how these effects become more severe with different levels of alcohol consumption. And basically that measure of 0.05 grams per 100 milliliters for blood alcohol is a standard that's applied in many countries, which roughly equates to a doubling, or sorry, a 50% increase in injury risk. This is not new information. So these same levels of drinking were described about 2,500 years ago by someone called Eubulus, a Greek poet in the 4th century BC. I'm not going to read the poem for you, but you can see how these different effects are calibrated and have been understood for thousands of years. So this is not new information, and which is why we can so carefully determine the levels of acceptable level of alcohol for operating heavy machinery, for driving motor vehicles, and so on. It's a very standard measure that's been carefully calibrated, which is not the case for many other drugs. Now, in terms of understanding the prominence of alcohol as a risk factor for road traffic collisions, when we apply those different risk measures to your crash risk, many of you will have seen this curve, which shows how your risk of crash involvement increases and increases exponentially at different levels of risk. So you can see the limit of 0.05. The first red bar is where South Africa's current legal limit is, and that dramatically reduces the crash risk from the previous limit of 0.08. So one of the key strategies to reduce risk is to lower the permissible blood alcohol limit for driving a motor vehicle. And these have been carefully calibrated for men, for women of different weight groups. And if you're interested in reading about these aspects in more detail, the WHO has a drinking and driving manual, which contains a lot of very interesting and useful information. In South Africa, however, it demonstrates why we can't just focus on drunk driving legislation. This is the profile of transport user groups by blood alcohol concentration in Cape Town over about sorry, the metric is wrong. This is about a 10-year, sorry, this is a single year. The single year in Cape Town, we can see railway fatalities, driver fatalities, passengers and pedestrians. The blue parts of the bars show 0 blood alcohol. The yellow parts of the bar show legally permitted blood alcohol. You can see for drivers, approximately half have no blood alcohol, have no alcohol on board, but for pedestrians, it's about 60 to 70% test positive for alcohol. And pedestrians are by far the single greatest user group for fatalities. That's quite dated information. But even if we look at more recent information from 2017, a national perspective, I don't have the same level of detail here, but you can see that for drivers, almost half of the drivers killed on the road were above the legally permitted blood alcohol limit. Pedestrians, similarly, approximately half. So we can't focus purely on drivers when alcohol is also putting pedestrians at risk. Showing the pedestrian risk by years, again, Cape Town data over about a 10-year period, you can see distinct peaks in alcohol positive cases amongst young adults in particular, peaking at 30 to 39 years. And so if we focused our efforts purely on drunk driving, we wouldn't really make any inroads and reach these groups at all. And I'll get to that in the next couple of slides. So firstly, let's understand how we reduce harm for alcohol. There are a number of strategies. Very important grouping is the drink driving countermeasures. There's strong evidence base for these strategies to reduce alcohol-related driving. The first is to lower the BAC level for drivers to, and what we're considering in South Africa is reducing to 0.02 grams per 100 milliliters, which is approximately half of the current legislation. Testing blood after serious crashes, and then also enforcement of local public drinking bylaws. But this obviously only goes some way and speaks specifically to drivers. And if we want to make a massive difference at a population level, we need to be considering other strategies, limiting availability of alcohol overall, increasing prices, reducing advertising and changing packaging requirements, and then also treating incidents after crashes or people with alcohol dependence issues. We need to have services in place for them. If we are to reflect on the status of some of our alcohol harm reduction policies, what we can see is, despite the experience during COVID, that most of these have stalled at the national level and at the provincial level, whether it's marketing and promotions, or whether it's the road traffic amendment bill, or local efforts to reduce alcohol harms, such as in the Western Cape, where we have a very progressive white paper, but there has been no follow through. One of the reasons for that is the influence of the alcohol industry at very high levels. So these are the commissioners that determine the national planning framework for our country over the next 20 to 30 years. And you can see that 3 of the commissioners are very strongly, well, you can take my word for it, have very clear links with the alcohol industry and are able to exert influence. And we see it at a local and provincial level. So the picture of the school, for example, is showing a primary school where a public health campaign is being underwritten by a local tavern. So this is what we faced with in trying to implement alcohol policy. I'm not going to talk about the conflicts of influence, but just to mention that we need to be very careful as public health professionals not to be drawn into specific harm reduction strategies such as drink driving. It's one that is favored by the alcohol industry, whereas the approaches that we should be taking are much more upstream and involving the population as a whole. So the word of warning is to be careful of what we're calling responsible drinking programs, which is a bit of an industry ploy. And what we really should be doing is focusing on reducing alcohol at a population level. I think best for me to pause there. I think with time constraints, I've got some other interesting data to share, but I think maybe we can pick up some of that in the discussion, because that's about 15 minutes for me. Thank you very much. I'll pause there.
Thank you, Richard. Excellent talk. I mean, I think it's amazing the data that you showed, that a large proportion of persons involved in road traffic crashes are the pedestrians who are under the influence. And I know from a recent audit that we've done at Tigerbird that many of them are walking on the highways or the motorways, or the cars are going at high speed. And I'm just sort of contrasting that again with anecdotal evidence, but maybe other people can chime in who live in high income countries where it's very unusual to have pedestrians walking on highways and sharing those roads with cars moving at high speeds. I don't know if you want to comment on that at all.
Yeah, absolutely. I think South Africa is quite unusual in amongst developing countries in that we have a very sophisticated road infrastructure, which allows cars to move at high speed. Whereas in many other countries, the road infrastructure is not very good. So the collisions that happen tend to be at a lower speed. I think most pedestrians that are hit in South Africa suffer very severe injuries as a result. And our speed limit, I think, is in most places is 60 kilometers per hour, which is sufficient to kill 90% of pedestrians at that speed of impact. So even on standard suburban roads, pedestrian crashes are often very, very severe. We did a study in South Africa about a decade ago and tried to synthesize all of the risks and prevention strategies, and it boiled down to controlling two. If we could reduce speeds, manage speeds effectively, and reduce alcohol exposure amongst the population, drivers and pedestrians, we could eliminate 60 to 70% of fatal crashes just through a focus on two risk factors.
That's amazing.
That combination.
And I think that addresses one of Dr. Martin's many questions, but I think Dr. Martin had sort of asked, what were the rate of return or what kind of public health measures would really reduce? And you talked about mortality from road traffic crashes. So you mentioned speed and alcohol. Dr. Martin, I think you're still online, but you had a couple questions there. Did you have a burning one you wanted to address to Professor Mostopoulos while he's still, while it's in your mind?
Well, Dr. Chu, first, I don't know if you can hear me. Can you hear me? Oh, great. Well,
yep.
First, thank you very much for organizing this. For those of you online, this came out of the incredible conference that was led by Dr. Chu and the teams at Stellenbosch, and incredible teams there, and a great presentation by Heike. And we spoke about advancing this. But I would like to ask, if I could, about the lack of a seeming political attention to something that is such a devastating cause on loss of life and disability, particularly for the young. And maybe any of the speakers, Dr. Chu or yourself, can actually share with the audience what is the status of the political interest in this public health catastrophe, and what do the audience, all of us around the world, should be doing to implement the evidence-based public health measures that you are all sharing with us today. Thank you.
Richard, do you want to take a stab at that? I think Heike still has to give her talk, so we might let her respond a bit later, and maybe time to think about it. But I don't know if you want to say anything now, Richard, or you want to save it, think about it for the discussion.
I've worked in the policy space for both road traffic and alcohol. And they're different, in my opinion. It's very personal, but there are barriers, the different barriers in both. I think for alcohol, there are the commercial interests. And so where I go to in the next few slides is to show the dependence of the alcohol industry on this harmful drinking pattern. So if people, there's a marketing line about responsible drinking, but if I show that if South Africa drank responsibly across all sectors of society, it would shrink the alcohol industry by 2/3 to 70%. So 2/3 of their profit, their sales, their turnover is dependent on this harmful drinking pattern. So there's a real vested interest in trying to keep people drinking at risky levels, and a huge amount of money spent on exerting political influence to ensure that the status quo is maintained, which is why all of those policies are stalled. Interesting, when you speak to policymakers, though, they can easily use the industry lines about victim blaming, but also blaming the harms on a select few people that drink irresponsibly and ruin it for the rest of us. Whereas in actual fact, it's just a function of age. Policymakers are old, they drink less, young people drink at risky levels and they comprise the injury burden. So it's just a phase of life, but these messages have been carefully crafted by the industry to influence, to be palatable for policymakers to exert that kind of influence. So I've seen that with alcohol policy. With road traffic injury, my understanding is that it's a vice of old people to drive fast and to have fast cars. So they're quick to blame the young for acting irresponsibly with alcohol, but they consider speed and luxury vehicles and high speed travel as a vice that kind of suits people in power and at that level of society. And I don't think there's a political appetite for reducing speeds and reducing risk. Again, the fault of crashes is conveniently blamed on others, whether it's irresponsible young people that don't know how to drive or people that drink and drive. But I think there isn't an appetite to change the current lifestyle decisions around road traffic, which is, I guess, again, is a function of marketing. Anyway, that's my long-winded answer. I don't know how much of it is true, but it's my personal take. Thanks.
Yeah, and I think we can take this up again in the discussion because I think it's very complex and multi-pronged. Although when you mention that there might be that the political message is often the blame, it is just a few targeted irresponsible groups doing this and giving drinking a bad name. It sort of has echoes parallel to gun control in the US, the argument around why we don't need better gun control. But anyway, that is a digression. I'm going to move on to the next talk, share my screen. The next talk is by Marion Sinclair. She is a civil engineer at Stellenbosch, and her academic interest is road safety.
Right, good morning, everybody. My name is Marion Sinclair. I am a lecturer in civil engineering in the University of Stellenbosch, and I specialize in road safety. So I'm responsible for teaching our third year civil engineering students how to design roads with the road user, the end road user, in mind. Today, my talk is a very introductory talk about the models that have underpinned our conceptualization of road safety as a society and why those matter. Our students in civil engineering often challenge us on the relevance of some of the more theoretical models that they are expected to know. But in road safety, the models that we use have a very direct bearing on how road safety has been conceived of, particularly over the 20th century. And I wanted to have a look at that today. I'm sorry that I'm not there in person to deliver this in lifetime with you. I'm sorry also to be missing out on the presentations from my colleagues on this panel, but I hope to catch up with those presentations and with my colleagues in the near future. So let's get on to the first slide, which is a very schematic, very simplified version of the traditional crash causation model. And this is really the road safety model that has underpinned most of how civil engineering as a profession has responded to road safety in the past. You can see that there are three elements here. The pink little blob is the road, which according to this model is responsible for between 5 and 10% of crashes. The little blue blob is the vehicle, again, 5 to 10%, and this differs slightly from country to country. But the big yellow blob is pretty standard across the world, and this is where driver or the road user themselves sit, and traditionally, historically, they have been accorded responsibility for about between 85 and 95% of all the crashes that occur. All of these obviously take place within a social context, so driver behavior might be different in one country from another country. Some of the vehicle conditions might be different, and obviously some of the road designs and the quality of the road environments might be a little bit different. So the social context is something that it is important to take into account. I've included this headline from one of our local South African online newspapers because it really encapsulates how we conceive of that human element in crash causation. So this obviously was related to a serious crash on the M17 back in 2022, so not so long ago. And it's very typical of the kind of media reports that we get following a crash, where immediately there is a pronouncement of blame. So driver error in this case, and in most cases, is found within hours of a crash to have been the fundamental problem, the reason that that crash happened in the first place. And so that 85 to 95% has really become such a dominant part of how we think about road safety. And road designers who are responsible for the roads, when they see a figure of between 5 and 10%, have been able to be fairly complacent about their role in all of this. Because if their road design is only causing a small percentage of the crashes, then frankly, they probably think they have been doing a decent enough job. Which brings me to our fundamental road safety problem. And I think we underestimate many times the fact that today's road traffic is inherently unsafe, and it's getting more unsafe all the time, especially in low and middle income countries where levels of motorization are growing. The road traffic system was never designed with safety in mind, as was the case with air transport or rail transport. Safety has always been really retrofitted onto roads that existed primarily for mobility. And that means we are almost fully dependent on whether a road user makes a mistake or an error in preventing a crash. We tend to be able to take a back seat to say, well, the road system is fine. The crashes only happen because of human error. And that means that as a society, we're very vulnerable. We've kind of left the responsibility down to the individual road user. We do, I believe, have a very simplified idea of how crashes occur. And I think our ability to be able to blame drivers in particular for crashes really belies the complexity that exists in crash causation. One of our preeminent traffic psychologists, a man called David Sheenar, back in 1975, but he said something really quite important. He said the majority of collisions occur to individuals who may not have performed perfectly, but who are certainly not acting in a deliberately risky manner. And he goes on to say, we've created a traffic system in which average and expected performance can result in a crash and subsequent injury or even death. And that is what, almost 50 years ago now, that he had this insight, that our traffic system is not as safe as we like to think it is. The model that we have allows blame to get in the way of making real changes. And as a result of our adherence to the kind of blame culture, we haven't really thought holistically in terms of crash prevention. And that was the situation right through the 20th century. In the late 1990s, Sweden started to shake the tree a little bit and came up with what they call Vision Zero, which is a whole new concept around the road safety model. And they believed that it wasn't important to prevent all accidents. And they said it's not possible, in fact, to prevent all accidents because we're human, we make mistakes. And as David Sheenar pointed out, mistakes are just inevitable in the road network. But the Swedish approach was to prevent any of those errors resulting in a death or serious injury. And so Vision Zero really became quite a novel approach and has become part and parcel of the safe system approach, which I think many of you will have heard of, and which is now the system at the heart of the international approach to the prevention of crashes that we've been collaborating around largely since around the early 2000s. The safe system approach also recognizes its starting point is also that crashes are inevitable, that the goal is to make every crash survivable. It has a tenet of shared responsibility. So for the first time, it's saying everybody who uses the roads, everybody who's involved in the design, the maintenance of the roads, and even professions like the health industry has a responsibility for making sure that our road network is as safe as possible and that our road users are protected at every possible point of their journey. It is a model that allows for more accountability because there is now more clear responsibility. And it also increasingly and usefully for the civil engineering industry provides practical advice and design guidance as to what constitutes a safe road design. So if you think back to the model that we started with, there is now, well, as of 2003, Rod Kimber's new model reshapes that model and the components of that model in a different way. And in this model, you can see that the system failures are responsible for the vast majority of crashes. Driver failures or excesses, so these are the intentional decisions to engage in dangerous driving, those account for a smaller amount than probably, certainly our politicians would like to think, and that driver failures as a result of an experience are also contributing to some of the problems. But a lot of the system failures are a result of humans just being unable to keep safe, to read all of the cues, to interpret an environment, to understand the behavior of other road users in an appropriate and complete way. There are some challenges to adopting the safe system approach here in South Africa, and possibly other low and middle income countries will face similar challenges. The first is that road safety is still not seen as a preventable or a systemic problem, that we still have this adherence to let's blame the driver, because that's always the obvious one to go for. And so we still focus on individual failures and not really yet on how our traffic system enables crashes. And that change has been made in many other countries, but not quite here yet. Locally, there are no positive improvements to take encouragement from, and that's a real shame, because I think once you start to see a positive change, it's easier to build on that. South African authorities, like many other developing countries, have got other priorities. Best practice from other countries is often deemed irrelevant. This is a very strange thing in South Africa, where we tend to think that we have unique problems and that we need unique solutions, which is not at all the case. And there's some really excellent best practice examples that we could and should be taking advantage of. Here in South Africa, and again, I think in many other countries, there's a massive legacy of road safety ignorance. There just hasn't been the investment in road safety education for many, many generations. And people don't even know why they should wear a seatbelt, for example. They don't know why their child would be safer in a car seat than sitting on their lap. And there is also, in South Africa, an extreme disrespect for traffic laws. And that probably is tied to the disrespect for the rule of law in general, but also a disenchantment with traffic authorities and a suspicion that, or many of those authorities, are responsible for corruption. But there have been moves to share the system to improve road safety, and I really am encouraged to see the medical profession getting more and more involved in road safety. I think that's a very hopeful sign that we're moving towards a system-based approach here in this country. Across the health sciences industry, there's definitely been a commitment, a new commitment to preventing crashes, not only to dealing with the aftermath of crashes. And I think increasingly how the health industry can assist with this is educating the public through disseminating your research results around issues like seatbelt use, alcohol, and crash likelihood, the impact of speeds on injuries, and that kind of thing. There's also a greater education of patients happening in communities, GPs being more involved and more proactive in encouraging the use of child car seats, for example. I think there's also a role to play in reporting more effectively to the government and to communities about the costs of crashes. I think the more our government and other governments, all strapped for cash, recognize how expensive poor road safety levels are in a country, the more likely we are to see better investment in road safety. Another role that the health sector is playing in road safety is researching and highlighting social equity issues in crashes, and we are involved in a collaborative project with the Tygerberg Hospital around this at the moment. And ultimately together, I think, working across our disciplines, lobbying authorities for change and for better road safety budgeting. So I think that there is definitely a positive change happening in South African road safety circles, that there is now a much greater acceptance of a shared responsibility and a much greater appreciation for the fact that crash causation is not as simple as pointing a finger at the driver and saying, there's our problem. So that is the end of my presentation. I think I have, yes, there's my email address if anybody needs to contact me. Thank you for your time and enjoy the rest of the presentations this morning. Thank you very much.
Yeah, that was a great presentation. Marion Sinclair gave a similar talk at the Stellenbosch CUGH conference in October last year. And I think it's just amazing to share the stage with engineers because they really do look at the whole problem of road traffic crashes from a very different background. And I would love to be able to ask her a bit more about what she thinks about automatic cars or driverless cars and if that would improve the system at all. Keith, I don't know if some of your questions were addressed by some of what Marion had said in her last slide about the areas in which we can intervene. I know that it still doesn't really answer why there's the gap in why these things aren't prioritized, but it does seem like she mentioned a few things that could and should be highlighted.
No, thanks, Catherine. Your speakers are really giving us incredible solutions, showing the obstacles, which is really helpful to us, I think, to understand where the pressure points could be for our efforts. And I just want to say from our perspective, we worked with Kathy Silverman at the Global World Traffic Association. I forget its actual name, but they are in the space. We'd be really happy at CUGH to work with all of you, and Dr. Chu's on our board knows this, to be able to advance the policymaking solutions forward. And importantly, as was mentioned, to bring in other sectors. I think Dr. Giegold, Heike, you mentioned the insurance companies and others, but it's fractured. We can perhaps bring some of the private sector folks together with some of you in our biomedical sectors and engineers to build a coalition, a forceful, evidence-based, powerful coalition to be able to move this forward. So I just say, after this conference, when things settle, we will work, we'd love to work with you to be able to advance this in a deliberate manner. Thank you very much, Dr. Chu.
Okay, thanks for that. Let me continue on. And the next talk is going to be given by Judy Fleiter again. She might work for the agency, Keith, that you were mentioning. She works for the Global Safety. Let me just find her talk here. It'll say the differences in road
Global Road Safety
She works for the
Partnership.
Global Road Safety Partnership. Yeah, thank you for that. I'm just going to skip over her intro because it's exactly the same as the other one. Yeah, the Global Road Safety Partnership. And they've done just amazing work. I think Judy Fleiter, Keith, would be somebody really to get involved with. They seem to be doing lots of sort of very like implementation science of trying new interventions and seeing if they make a difference, which might also address to kind of what you were saying, what's the bang for your buck. Okay, without further ado, I will play this one.
I'm delighted to join you to discuss the differences in road safety attitudes globally. And I'd like to just summarize, I guess, what this session will cover: similarities and differences across a range of factors relating to our attitudes to road safety and to road crashes. And I know that you're familiar with the impact of road crashes globally. The point I'd like to highlight here particularly is the bottom point on this slide that tells us that there's a 3 times higher death rate from road traffic crashes in low-income countries compared to high-income countries. And so I just would like you to keep that in mind as we move through this because it's important context. Additional context to share is that not all low-income countries are the same. That might sound obvious, but often when we're talking about the low and middle income country context, we say that in one simple sentence as if it means the same thing. But a reminder to myself as well as everyone else, not all middle income countries are the same and not all high income countries are the same. And I think that's important context for this discussion. In fact, another way that I like to remind myself to think about these issues is it may be that urban environments is a better way to think about road trauma and road traffic crashes across the various aspects. So urban environments across different countries might be a useful comparison, and the same for rural and remote environments. Now, why do I say that? Well, you'd be very aware that some low and middle income countries have huge cities, mega cities, in fact, that may be at a level of readiness to implement road safety interventions that are similar to high income countries, particularly when compared to rural or remote areas across the globe. And so a question I have for you is, doesn't everyone want to be safe when using the road? I think the universal answer to that would be yes. Another question is, if I ask any single person on any day, would you want to come home safely today? I think universally the answer would be yes. And if I were to ask any parent, do you want your child to come home safely today? Again, universally, I think the answer would be yes. So what context can influence the outcome of that question? Because if the answer is always yes, then something is different. Something is being prioritized differently because we've got such different outcomes in the countries around the world. And so I'm going to talk about a range of factors here that can help influence our thinking in that regard. One is a group of psychological factors, as I call them. Behavioral adaptation is one. We're very good, we're adaptive creatures, human beings, and we've had to adapt to increasing levels of motorization and also to globalization, migration within countries as people move from rural parts of their country to big cities, but also migration across borders. And so we've had to adapt the way we behave on the road, and that doesn't always end well. There's also risk perceptions to think about, or misperceptions about what we think is harmful, and speeding is a good example of that. And also we may have misperceptions about how likely our risk is to be detected by police and how likely it is that we will receive a legal sanction if we're breaking the law. And then beliefs and attitudes more generally. There are different beliefs about what causes a crash. So crash causation, attribution of crash and attribution of injury causality. And I have worked with colleagues in Pakistan, for example, where we explored religious, fatalistic and superstitious beliefs about crash causation, whether crashes should be investigated or not. Any scientific evidence was really overtaken by cultural and superstitious beliefs. And that can also influence whether people believe there is a need for policy and legislation, and also whether that should be enforced or not. And then there, of course, there's the broad range of normative beliefs, community norms, subjective norms, our moral and social norms. And one way of capturing the essence of how different attitudes can be is a project I'd like to describe to you. I wish I was directly involved with this project. I'm not, but I highlight it here in case you're not familiar with it. It's the ESRA project, the e-survey of road users' attitudes. If you're not familiar with it and you're interested in this topic, I encourage you to look at it. A joint initiative of many institutions and research centres, services and private organisations. And it aims to collect and analyse comparable data on road safety performance, particularly road safety culture and behaviour and attitudes. So I encourage you to have a look at the ESRA website. Just to give you a sense, there's some information there on the screen of the types of road users that are surveyed regularly, the themes and topics that are covered, and you can see that there's a lot of attitudinal and behavioural issues, particularly the behavioural risk factors that have been discussed today. And ESRA 1 was conducted in 2015 with 17 countries surveyed. ESRA 2 was 48 countries. So it really is a great comparison across the globe. There is, I believe, 6 continents were involved in that 2018 survey, and another one will be conducted this year. So you may not be able to read all of that, just a snapshot from the ESRA 2 report, just to give you a sense there of what attitudes and perceived behavioural control measures were used in that ESRA 2 survey. So it's an extensive examination across 48 countries. I encourage you to have a look. I'm not going to give you the results of it. There's not enough time. Please seek that out yourself if you're interested. And so just coming back to traffic safety culture, it's some work that I've been involved with colleagues for a number of years now. And here just noting that traffic safety culture models in non-Western countries require an understanding of the relevant social and cultural factors that influence behaviour. It's an important concept to remember. And one that I like to particularly point out is social learning theory, or social learning and modelling of good behaviours. And I'll use the example of child restraints, where in some countries a child is restrained from a young age in a vehicle and they're familiar with, you know, a safety harness or a child restraint mechanism. And so that can influence their restraint use throughout the rest of their life. In other countries, we see children who are growing up not familiar with restraints. And sadly, only a small number of countries have good laws about child restraint use, only 33 countries at last survey in 2018. And so there's a lot of children growing up who are not familiar with being safely restrained in a vehicle. Political factors also come into play here, limited recognition among governments of global road safety trends and a lack of understanding about where to start. Inability of governments to recognise and prioritise road safety amongst many competing priorities. Very strong industry persuasion relating to safety standards. And governance and corruption issues, complicated legal procedures, and there's often a lack of trust in the criminal justice system, which colours the population's understanding of laws and the justice system. Then there's practical factors, challenges in land use planning, particularly in urban environments. There's perceptions or misperceptions about the need for more private vehicles, for more space for more vehicles, and this leads to deprioritising active mobility and public transport. Looking at provision of safe and affordable transport options amid ongoing population expansion. And we're looking to build appropriate and sustainable levels of capacity among road safety professionals in country. And this can have there's a detrimental effect when there's constant staff turnover, particularly at senior levels, the inability to transfer knowledge on to the next generation. And we all sometimes see that in-country advocates are not always willing to push for international best practices when advocating for new legislation to protect the population, and that can have a knock-on effect of people not understanding that there could be laws that can better protect them. And so in closing, I draw your attention to this image that was actually taken by a friend of mine who was on holiday and just sent it through. That helmet wearing is now mandatory even for women. That statement in itself says a lot, I think, and just helps us orient to the thinking of that particular community at that particular time. So in closing, a reminder that low and middle income countries, though we talk about them as one group often, are not homogenous and have different needs, just as high income countries are not homogenous. And importantly, personal and cultural attitudes, beliefs and perceptions have a huge role to play in how we use the road, how we perceive risk, and how our governments prioritise safety interventions. Thank you very much for this opportunity to contribute.
That was a great talk. It just made me think when she said not all low and middle income countries or not all countries are homogenous, in the sense that in Rwanda now, helmet laws are very, very strictly enforced for their motorcycle drivers. They have motorcycle taxis. And to compare and contrast that with the neighboring countries of Uganda and Burundi, where they also have motorcycle drivers, but without helmet laws, and the difference in road and traffic mortality there. I did want to ask Richard one question, because Judy brought up the question about road safety attitudes. And it is kind of my perception in South Africa, Richard, but maybe you can correct me if I'm wrong, but the attitude around drinking and driving seems to be quite relaxed, even just amongst the well-educated and sort of middle class, that, you know, when they talk about drinking and driving, they mean other people, but not really me, the person that's had a few drinks at my friend's house and then going to drive home. And Richard, I don't know what you think is the attitude to being able to change that, or if you believe that's true, and if that's been different in other countries, sort of drunk driving.
I'd agree. Yeah, I'd agree with you, Catherine. But I also think that it's a systemic issue, and there's a tolerance for it. There is if you look at how strictly drunk driving laws are enforced in countries like Australia, where they set a target of testing one driver per year for drunk driving, and compare that to South Africa. I do a quick test in master's class when I'd teach that module, and I think we calculated that your risk of being tested for blood alcohol is once every 50 or 60 years. If you tally up the number of driver years in the class and how frequently people are tested, so it's tolerated at a societal level. There's no investment in testing, and people get away with. It's inconvenient to stop drinking. Alcohol has a psychoactive effect. So you might not intend driving drunk when you go out in the evening, but when you've had a few drinks, you know you're not going to get tested, and so there isn't really any type of sanction on drinking and driving. So I think it's not purely a personal attitudinal aspect, but it's a societal tolerance for drunk driving that gives rise to the behavior. Very often we always want to point fingers at people, but generally it's upstream. It's what we accept at a political level or at a societal level that determines whether people drink and drive at least.
Yeah, good comments there. Okay, I would like to introduce my next speaker. It's Dr. Heike Gedult, or Professor Heike Gedult. She is the executive head of the Division of Emergency Medicine at Stellenbosch University, and quite involved in road traffic safety and pre-hospital transport, among many other things. So Heike, take it away.
Thanks, Catherine. Let me simply just make sure that we are appropriately presenting. Are you able to see?
Yes, you are on.
Fantastic. So, well, thanks everyone. And it's really been an amazing session up to now. I'm learning so much, which I think is what's happening continuously as I'm in this learning about road traffic crashes. And as a global health practitioner, I'm becoming more aware that the big problem has just not been taken center stage for so long. And as Catherine said earlier, road traffic injuries are the leading cause of death of young people around the world. And this to me is such a chilling thing, because it's not a priority in how we as global health push our efforts into the world. It's not necessarily a funding priority. It's not necessarily a research priority in terms of the leading cause of death in young people. This is an area we can make a significant difference. And I think one of the big strengths of having this session today, I hope, is that we start to take this message into the global health community in a much stronger way. One road user will die every 23 seconds around the world. And that is a terrifying statistic. And I keep thinking that if the average layperson could internalize that, we would be directing a lot more funding and a lot more scientific efforts towards preventing road deaths. But I think, as both Judy and Marion had said earlier, there seems to be a perception that it isn't something that can be fixed. Whereas perhaps what we should be looking at is a very much a global health solution-based approach, and selling the idea that there is a solution may just be the strongest weapon we have. So Catherine mentioned earlier that we'd missed our goal for the previous decade, for 2011, 2020. And I'm thinking about how we globally change that. How do we make sure that this decade is the one where we actually have the reduction, so that we don't have to have a 2031, 2040, another decade of road injury? There has to be a pivotal point where we, as a global community, can make significant changes. So the decade of action for road safety, Marion has spoken about the safe system model. We've spoken about the cultural perceptions around road safety. But how do we as a global health community engage in the decade of action, both as clinicians, as public health practitioners, as people involved in NGOs and the political space? We must have some cohesive approach. And the approach does already exist. The Decade of Action of Road Safety, as many of you may have seen, it's been mentioned in most of the presentations thus far, has a global plan. It does advocate the safe system approach and speaks to the multiple actions that we should be involved in, from land use and transport planning and road infrastructure, vehicle safety, safe road use, which alcohol and the cultural aspects are involved in, distraction, and the need for a post-crash response. And then as an emergency physician, that is obviously is the way that I entered the road safety world. But what I've realized is that it's not one single element, it is all of them. And the challenge is, how do we, as a global health community, get involved? And I think one of the most important aspects for me, as I'm sitting in South Africa, in Cape Town, is that low middle income countries bear the greatest burden. Any impact that we can make in these settings on a global level is going to have the greatest impact. And so that's where we're going to get the biggest bang for our buck. And the most important part is that road traffic crashes are an equity issue. It disproportionately affects low and middle income countries. Half of all of the deaths are in vulnerable road users, so those that aren't protected by a vehicle. And it kills young men. But often the burden of the death of young men is felt by women because these are usually the breadwinners. And we know that these unequal impacts extend to ethnic and racial groups, to socioeconomic status. It is the poor that are affected the most. It is those who, by virtue of their socioeconomic position, are the ones that suffer the most. And so we have a moral obligation to be pushing actions around road traffic. Marion Sinclair, who spoke earlier and is a colleague of ours, is a fantastic researcher on looking at all of the equity issues along with the issues related to the technicalities of a safe system. And she's found that there are clear age and gender norms, and we know that it's documented around the world. In South Africa, it is the same. It's about 3/4 of the deaths are related to the male population. And it's simply about where people are placed. But in terms of global health equity, if we're looking at solutions and we're looking to see how we can make the biggest interventions, we have to really be thinking about how we both describe it and how we think about the interventions in terms of our context. And so it's not necessarily just useful for us to have a single standardized plan and a single standardized approach that we use in every country. As Judy said earlier, not every low income or middle income environment is the same. And contextual factors are critically important in road traffic crashes. The problem with having multiple interventions or having interventions which fail in some areas because we haven't taken into account the context really does disrupt this global movement towards having a significant impact. And so it's really important when we look at designing solutions or impacts that they are incredibly context specific, that they respond to the local needs. And this was a paper that was published last year, which comes from the MRC as well. And what I really liked about it is that they describe the inequity amongst road users in terms of this fabulous system that sort of replicates that model that Marion put there. And it talks about the user being nested within the system, which is nested within the context. And any intervention that we do has to rely that these three elements are interconnected. And so this was a study from South Africa that looked at this user system context and looked at vulnerabilities. And what was interesting for our particular context. And for some of you, this may be very different. And perhaps just to contextualize, South Africa's road use mix is an interesting one. We, like most African countries, have a high level of pedestrians. About 40% of people on the road are pedestrians versus 12 to 50 to 20% in most high income countries. And that road use mix does affect how, sort of where the injuries are, where people congregate, and the types of solutions that we have to focus on. And so for us, because we have this higher pedestrian risk, and this risk is often related to public transport and the nature of roads. And those areas where there is what they describe as area level deprivation. So the poorer areas, people in lower socioeconomic areas need to use public transport more. They live closer to roads. They live in areas where there is inadequate safety provisioning for pedestrians. They don't have sidewalks. In addition, there's often informal commercial activities on the roadside, which draws people to these spaces and congests these areas. And all of that increases pedestrian risk. But we also, because of the socioeconomic structure of the country and the spatial planning, much of the legacy of apartheid in terms of spatial planning has meant that the poorest of the people are furthest away from the central business district. And so they're furthest away from where they work, and they rely heavily on public transport. And this public transport has certain patterns that place people in certain positions with increased vulnerability. We also know that being in a rural area, your risks are much higher. Not necessarily your risks of crash, but a much higher chance of having a severe crash in a rural area because of the quality of the roads, because of speed. And along with that higher crash severity is also poorer access to timely and adequate emergency care. And that's something that we see all of the time. One of the things that was interesting, and I think speaks to context and culture, is around female road users, and particularly in urban areas. So in South Africa, we found that females are more likely to use public transport, and therefore more likely to be involved in a crash involving public transport. They're also more vulnerable in this case because they tend to travel with children or have loads, and so cannot negotiate where to engage with public transport, and often get picked up on the side of a road, often a freeway. And so those are really specific sort of context and system specific vulnerabilities. And if we didn't think about it in that term, then any intervention that we create that is standardized wouldn't allow for those specific contexts. And understanding local context and culture is critical to prioritize and design appropriate interventions. Catherine mentioned earlier this South African idiosyncrasy, and it's not necessarily just us, but we have very well designed freeways, a good road infrastructure. I think Marion would disagree that we're not necessarily pedestrian safe, but we have cars traveling at high speeds. And as you can notice in the background, we do have pedestrian overpasses. But like Brazil, Uganda, places where they've reported similar studies, these pedestrian overpasses are hailed as a new safety option to stop people from running across the road, from dodging traffic in order to get to an area on the other side, or to connect with public transport because taxis usually stop. And people are running immediately underneath. And part of it is about positionality, about where they need to be in time and distance, and it's easier to travel on grade. But some of it is related to safety, because those pedestrian overpasses are often a site of criminality. And so people often choose to dodge cars that they can see, as opposed to walking through those very restricted pedestrian overpasses where they know they might be robbed. And so these are choices that people are making. And so the impact of these pedestrian bridges is much less than we would hope in these communities. If we simply looked on paper, they make lots of sense, but understanding the local context means that we realize that they probably aren't the ideal. And I'm sure all of you can think of different interventions or advocacy campaigns that somehow miss the essential ways that people live in certain areas. One of the things I did want to bring to this group in particular, because it is a group that is involved in global health, is around how we as responsible global health practitioners, both in terms of our research and developing interventions and solutions, can be thinking about the ways that we describe road traffic injuries and also how we describe interventions of them. Those of you involved in systematic research or the Cochrane Group might recognize the Progress Plus framework. Originally, the Progress framework was developed by Evans and Brown, who actually very early on in its development contextualized it around road traffic crashes. And they spoke about it in the context of health system reform. It's simply a way to discuss that there are different factors and social determinants that contribute to inequity in health, and in particular in road traffic accidents, because the socioeconomic position, and that's around income, welfare, affluence, but in this case related to road traffic, it's where people are placed structurally within the environment, what infrastructure is built around them, what access they have to different ways of traveling or all of those have particular impact on any intervention that we want to do in terms of road traffic. And I would hope that this is one of the things that we can take out of this discussion, is to frame any solutions or any interventions in terms of a Progress Plus framework, where we consciously and explicitly talk about the societal and structural factors that are affecting road traffic crashes in our particular context. Just to say that there is some good news, and so looking at different interventions for preventing road traffic crashes, on a search of the literature, one of the things that we do find is that a lot of the interventions, usually around enforcement, so policing, enforcement of legislation, most of that is in high-income countries. In this review, 33 of the 35 systematic reviews included came from high-income countries. And it's not to say that these interventions don't work, because they do. So many of the sobriety testing, the speed enforcement, but contextually they will come out of high-income countries, and then we can't necessarily translate that directly to low-middle income countries. And that's the challenge that we have, is to be able to understand how we can take interventions that work in some settings and be able to pick which ones have the largest likelihood of having a positive impact. This is one that is probably a little closer to my setting. We're focusing on pedestrian road traffic injuries. And what I liked about this is that there is already a description of interventions related to the different system, the user system and context. And in this paper, they described the user, the vehicle, and the infrastructure, and put a lot of the different types of interventions in these categories. A lot of it is again veered towards legislation, vehicle safety, and most interesting for me, of course, as an emergency physician, is the need, particularly around emergency care and early post-crash response. Because many of the pedestrian road traffic injuries, again, would happen in sort of low middle income countries, where that road mix is more pushed towards pedestrians than other forms of road user. Very briefly, there are different types of interventions, and we've done a few studies in Cape Town looking at seatbelt usage, and then looking at the socioeconomic relationships between seatbelts in different communities. So this was simply observational, not necessarily understanding the cultural factors that we would need in order to drive an intervention, but we have to start in some places. So finally, just thinking about the role of the global health community, I think there are so many things that we should be involved in when it comes to road traffic crashes. And one of them really is around research, and also in particular around surveillance. Because while there's a lot of data around road traffic crashes and road traffic deaths, there is a paucity of data around road traffic injuries. So crashes that don't result, non-fatal crashes, the impact of injury on communities, on families, the need for rehab, all of these elements that contribute to the cost of crashes, we don't have great data for, particularly in low and middle income countries. And then being able to create systems to monitor the patterns, because so that we can have a reliable way of measuring our interventions. We also need to look very specifically on the societal factors. I love this quote from Amatunga in the Lancet in 2006 that talks to its quantitative and qualitative research are essential to appreciate the burden of the determinants of road traffic injury in a meaningful, context-specific manner. And that's the kind of research that we need, is to understand and unpack the problem at multiple levels, rather than finding simplistic simplistic solutions to a very complex problem. And we need people to be part of the advocacy. If we want to have a whole of society-based approach, and as global health practitioners, it is a health problem, but it is a societal problem as well. But we need a system-based response. We do have a framework. We have a roadmap given to us by the WHO as to how we should be engaging. We need the momentum, we need the funding, we need the support, and we need the recognition of this as a significant priority. So this is another editorial by Marion Sinclair. She is amazing, and hopefully some of you will be able to make contact with her after this. Because one of the conversations that we'd had really early on is about the role of healthcare professionals. And we often feel disenfranchised to be able to engage on a community or legislative level or policy level around road traffic crashes. And she wrote this editorial in the South African Medical Journal, which is a generalist medical journal, to try and encourage healthcare professionals to be part of the solution. Because if this is seen in some settings as a health problem with the WHO as the lead organization, it is very hard when we don't have a body of healthcare professionals that are pushing this as a priority in our strategic agenda. And there are ways that we can do this, from advocacy for behavioral change, and Richard has spoken well about alcohol and road safety, and I'd be very interested to see how this at a local level, at an individual level, but then also at a policy level, how we can advocate. We need to be aware of the legal frameworks and be able to understand which are the ones we should be targeting for our context. So this is from the WHO Global Status Report. This is South Africa with a rather scary 25.9 deaths per 100,000 people. But if you look at our laws, this is a measure of the quality of our laws in this country. And other than good, adequate seatbelt laws, we don't have good laws on child restraints and speed and helmets and drink driving. And that's something that I think very few people actually who are entering the space are not aware of and cannot. And if we know this, we can engage. And this is where we should have a very focused advocacy around specific interventions. Just wanted to highlight this. This is a document that was released this year by the WHO on advocating for emergency care. It's geared toward non-governmental organizations. But interestingly, the topic that they have chosen is road traffic crashes as the way to advocate for emergency care, because it has such a clear plan for advocacy. And the targeted response is clear and is something that people can advocate for in a structured manner, in a cohesive manner. And it talks about the steps that are required, and target number 12 is to minimize time between crash and emergency care. And that's where the other priority is to build those emergency care systems to improve post-crash care. So we need to do better, more research. We need to be really focused in our research to not just quantify the problem, but also understand the social and societal structural factors underlying so that we can design appropriate interventions. We need to advocate on an individual patient level, person level, as well as on a community and a policy level. We need to work within the framework that has been given to us to do this work. And we need to advocate for and build emergency care systems to improve post-crash care. And that's what I have. Thank you so much. I'm going to stop there. Thanks, Catherine.
Wow, Heike, what an amazing talk. And I think you really just brought up so many things to be discussed, but I think some of the highlights specifically were, road traffic crashes is really an equity issue. And I think that makes it difficult. I think neglected diseases in general worldwide don't get the attention of the wealthy policymakers, the wealthy sort of high income communities, because it doesn't affect them proportionally as much. Road traffic crashes does affect people in all countries, unlike some of the neglected diseases like sleeping sickness, but certainly it's a top of some of their list would be more like cancer. They always use breast cancer because wealthy white women tend to get that, and then they tend to focus on that. So I think that, one of the things is how does it become more of a global priority? And I think you also mentioned context-specific interventions, and I think the footbridge example is the perfect one because like on paper, people would think, okay, we're going to make a footbridge over the highway to prevent pedestrians from getting killed by running across, but the, risk of getting raped or robbed on that bridge is high, given that there's no way off the bridge once you enter it. And so making especially female pedestrians more vulnerable isn't something necessarily that the engineers and architects who design those bridges would have thought about. So I think that those are important. I think the real question maybe to yourself and to Richard and to anyone else listening would be, where could we then target our interventions, given that it's so bespoke for different countries? I mean, for South Africa, we've mentioned several, you've run some specific points. And is there any kind of framework? You mentioned the Progress Plus framework to make sure we look at the social determinants in different areas. But, when the WHO is trying to make some sort of global policy and they've got all the different areas, is there something that could be appropriate for different countries? And if not, do we just work locally? But I thought maybe I'd kick off the conversation by calling out Lee Randall. He has made some comments actually in the chat that there is a SADC sort of alliance of NGOs around road safety. That's not something that I know about. And I was wondering, Lee, if I could put you on the spot to just tell us a little bit more about that. And for those that are not Southern Africans, what SADC is. Yeah.
Sure. I'll just try and get my video going. I'm not sure it's going to work. There we go. The SADC, so let me start with what the SADC is. It's one of the regional economic communities on the African continent, quite a big one. It has 16 member states at this point. And it's, as the name suggests, it's concentrated in Southern and also East Africa. The SADC Alliance for Road Safety NGOs was born in May 2021, so it's a relatively new alliance. And at this point, it has member organizations from 11 of the 16 member states, and we're busy trying to recruit NGOs or even help set up NGOs in the remaining 5 states. We are an associate member of the Global Alliance of Road Safety NGOs, which is a much longer standing, very well established, very well respected alliance that has just had its global meeting in March. And one focus of the global meeting, a strong focus, is holding governments to account. And they have launched what they call the Alliance Accountability Toolkit, which is really going to give NGOs a lot of clout in terms of shared knowledge and shared strategies, which have been proven to work in terms of lobbying governments and advocating for road safety and engaging civil society around the issues. So I'm a co-founder of one NGO in South Africa, which belongs to the SADC Alliance. We're called the Road Ethics Project. We're also very new, and we take a Vision Zero safe system and ethics approach, basically saying we have an ethical crisis going on, predominantly we're focusing on South Africa, but obviously there's a regional kind of cross-translation as well. And what we're trying to do is promote greater ethical literacy amongst road users, road designers, road safety enforcers, policymakers in particular, because although lip service is paid to things like the safe system and Vision Zero, it's not making it into reality in a place like South Africa. So our national road safety strategy is built on a safe system model. But if you hear people say from the Department of Transport speak publicly, they're still very much using the old model of it's all about individual behavior. So we as one NGO in South Africa are trying to occupy a different niche that we haven't seen anyone else occupy as yet. And we emerged actually from my PhD in the field of bioethics, which looked at minibus taxi crashes and how to ascribe moral responsibilities for addressing those. For those not South African, minibuses are our mass transit mode in South Africa. They're privately owned, profit-based, and do have high crash and injury rates. So there's a particular ethical crisis around the industry, which is also not government subsidized, the way the much lesser used modes of trains and buses, for instance, are subsidized. We have another 5 South African NGOs who belong to the Alliance. Because of the size of our population, the idea is to have at least one NGO per 10 million population. So Botswana, for instance, with a much, much smaller population, we do have one NGO in the Alliance. Yeah, so it's an exciting alliance. It's getting itself established. At this point, it's doing a lot of capacity building and knowledge sharing across the region. And it's also tapping into global alliance activities, such as their activities around the upcoming UN Global Road Safety Week in mid-March. Yeah, and doing a lot of supporting. The Global Alliance also has an incubator program that new member NGOs can join. And there's some possibility of funding through the Global Alliance, but funding constraints are probably the biggest limitation on NGOs as a whole, certainly in our region. I hope that wasn't too much. That's a quick overview.
No, thank you. And it's wonderful to hear about the NGOs working in this space. And I was wondering if you felt comfortable, if you want to share your contact details in the chat, because those of us working in South Africa, and Keith, I know you've been mentioning in the chat, working across multi-sectors. And I think the NGO sector would be a wonderful addition. Also, for those of us that aren't South African on the call, South Africa does have a history of advocacy from sort of a grassroots level. And I think that what could be missing in this whole global health solutions is the voice from the people, because we are complaining about our politicians, and we're complaining about the alcohol industry, and the toying, the protesting, at least for getting antiretrovirals for HIV positive patients, actually did work during a time that seemed very bleak in South Africa for that health advocacy. So maybe for road safety, it could be also something. I wanted to turn my question back to Heike and Richard. Heike, I'll start with you, and then to Richard about, then given all the things you said, Heike, what next? What are some actionable, small, concrete things we can do next?
I mean, I'm a rather strategic thinker, and I think the thing, having looked at all of the complexity of actions, I think for me, I think that we are constantly undermined by the current model of thinking about that, the model that applies blame to the user. And Lee made a good point. Today is the start of our Easter road safety season. In fact, this morning on the radio, I heard a bunch of messages, and they were all related to individuals, to the individual driver. And so I think it's a really difficult space to be able to make advocacy drives when that victim mentality, when that individual responsibility message is still so pervasive all the way through. And so I think if I was thinking about one of the things that has to be happen is we can't get people to push policy and advocacy when there is an alternative, and the alternative narrative is that we can limit alcohol, or we can stop people from using the roads because it's people making mistakes that are causing these crashes. And I think that if there was that change in the narrative towards it is the system, and that we push to report accidents, we're pushed to report injuries in view of the interaction between the user and the road and the context at every level, in the media, in the way that we engage in terms of health. I'm an emergency physician, so I know that, and even in my interactions with people who are patients who have been injured, I still have that narrative in my head that they shouldn't have been on the road, or they shouldn't have been drinking and then walking, and that injury. And you have to consciously move away from that if we want to have a bigger change. So I think from probably the thing that's going to have the biggest impact is change our narrative and language around road traffic injuries and road traffic crashes and road safety, and make that message universal. And then we'll probably get more momentum for all of the other activists. And personally, I do think alcohol in a South African context will have the biggest impact. And I'm sure Richard will tell us about that. Thanks.
Well, that's a good segue into Richard. And then Richard, I also noticed in the chat, you had mentioned a little bit about the hierarchy of risk, which I think would be great to maybe elaborate on a little bit more as well.
Yeah, thank you. I see my chat has been deleted from my screen. I think I had a break in power, so I don't know if it's still on the chat for the rest of you.
It is, but if you want to talk us through it a little bit, that would be fine.
Sure.
But it is up, yeah.
Yeah, so I was commending the GRSP speaker on speaking about some of the systemic issues, which is great, because we've got to recognize that this whole paradigm of road safety is shaped to some extent by the funders of the road safety industry. In a sense, it's also an industry, and people that are trying to put us on roads, or people that have a stake in the road environment, the petroleum companies, the vehicle manufacturers. It's a huge industry. And so even though we're talking about road safety, we need to recognize that roads aren't the only mechanism for human mobility. It's a construct that is being foisted on us, and we need to, if we're true to the systems approach, we need to consider transport safety or human mobility outside of a road system. And also consistent with the systems approach, the most important risk that we want to address is people's exposure to risk. And what that means, your exposure to risk on a road system is how far you travel and how fast you travel and what you're exposed to on your journey. So by far, you could be drunk without a helmet on an unroadworthy bicycle and travel from your place of work to your home, and if it's on a nice cycle path with no exposure to fast cars, and it's a kilometer, you can do all of those other risky things. You don't have to wear a helmet even. Most important thing is limiting your exposure to risk, and so really is an upstream equity issue. So if we've got in South Africa, Heike's example of vulnerable people living 40 kilometers away that have to use risky public transport, we have a decision of making the vehicles roadworthy, making the drivers test alcohol negative, be able to drive efficiently at low speed, or we can take those people and move them 30 kilometers to the closer to the city. And I would say the latter is a much more important road safety intervention than the ones we consider as road safety interventions. So I think being true to the systems approach, we need to look at how the risks cascade, and we always need to be looking upstream at the equity issues. So that's a little bit utopian or idealistic, but that really is the longer term big picture thinking that shifts road safety fundamentally, but it takes forever to get there. So then the next thing that we can look at are the big risk factors. And as I've mentioned, in South Africa, there are two of them. It's vehicle speeds and it's alcohol. Alcohol, straightforward. We know exactly what needs to happen to reduce alcohol risks. We've got a whole range of alcohol policies. I presented some of them for the road environment, but there are macro alcohol issues as well that we can deal with. We can impose minimum unit pricing, increase tax and excise, limit availability, limit advertising, all sorts of things that will change alcohol at a societal level. Straightforward, requires political will. Speed, sometimes counterintuitive, because we look at a road environment with pedestrians crossing the road and we think about what infrastructure we could put in place for pedestrians, but we need to recognize who was there first, the pedestrians or the cars. And so the technology that's being imposed on people is a freeway system with fast moving vehicles. It has no right to be there really, but people were there first. So how do we mitigate the impact of those fast moving cars? We can either put them underground or we can put them on freeways so they don't interact with people, because the people should have the primary access to the land, or we can reduce the speed of people on the freeway. So it makes no sense in Cape Town. We have the N2 that is 120 km/h limit. I think Heike's picture was of the N2. And all along the N2 are informal settlements and people needing to get to other modes of transport, to services, to clinics, etc. Why on earth do we have 120 km/h speed limit on a road in an urban center that's passing through communities? And the simple solution is to put speed humps on the N2, reduce the vehicle speed to 60 km/h. So you know, the fundamental things are reducing people's access and drinking, and reducing their exposure to high-speed vehicles. Those are the two immediate things that we can do that will have a population level effect. But beyond that, it really is an equity issue, and we need to be looking beyond the road environment at densification and urban planning and that kind of thing. Thanks. Over.
Thanks, Richard. And I think for those, you did mention the alcohol bans during COVID, but for those non-South Africans, you know, it was quite an interesting, I guess, identification of what is the impact of completely cutting out alcohol. So I think there were periods of 6 weeks or longer when the nation banned all alcohol sales. And then there were times when they tried to restrict the sales to certain days of the week and certain hours of the day. But it did seem that when they completely cut out alcohol, the effects were very dramatic on road traffic crashes and intentional interpersonal violence. Obviously, the government has now pushed back on all that to say that that was temporary and there's no way we could maintain that, but it is a good experiment to see what would happen in a country like ours. Because I think it's some of the naysayers of some of the things you've said about the labeling, about the size of the, you know, all those policies to try to reduce drinking, saying it's not going to help, it's not going to help, it's not going to help. But I think if you show that there is no access to sales, I mean, then we can see that there is a big difference. Just while we're seeing if there are any other questions, Heike, I don't know if you had a response to any of the things that Richard had said there, or any other comment?
Well, I was actually thinking about, as Richard says, the pushback. And it's often not only political. It is almost a philosophical kind of argument, you know, this restriction of the rights of individuals versus this, what we know is the greater good, which is, you know, we have people at risk, poor people at risk all of the time. And I was actually just quite interested to think about the Lee's actually mentioned there's an ethical argument to be made to restrict the rights of those that have the road, you know, road users that have access to the privilege of using the roads with vehicles that are able to attain high speed versus the pedestrians or those that are living close to a road, and how we build an ethical argument that might be able to sort of sway that and push back against that political power. So it was really just a question. I don't know if anyone has any thoughts on that. It might be quite philosophical for this time of day.
I can try, I can attempt it based on something that Louis Reynolds at Red Cross, I don't know if you know Louis Reynolds, once said about equity issues of private car ownership. It only works if people don't, if not everyone owns one. So there's a fundamental equity issue. You can only drive fast if other people don't have cars, because if everyone had a car, you would have gridlock. So the private motor vehicle system relies on inequity. I don't know if you can get your head around that a bit. I mean, it's quite, yeah, it does ring true though. So if you, so conversely, if you gave everybody a government issue car, you would solve the road crash problem, because the roads would be gridlocked. You wouldn't be able to move on them because it's such an inefficient mode of transport. But it relies on us having inequities. So people that don't have cars, so we can travel fast. The privileged can travel fast in the cars that are privately owned.
I think the person you're speaking about is a pediatrician at Red Cross who works for the People Health movement. But yes, and I'm pretty sure he walks to work.
He does.
He doesn't, doesn't drive. He's my neighbor. He's my neighbor. So you know.
I see Lee has a hand up. Yeah.
Okay, Lee, go ahead.
Again, yeah, I think what we as the Road Ethics Project really try to do is to shift paradigms. We think unless you get at people's headspaces, we're not going to see much change. So one of the things we do is take people through some general moral stances and get them to try and work out what their moral stance is. So for instance, the deontologists are totally caught up in the law, you know, and so they will feel okay if they're driving at 60 k's an hour in the rain past a school because the law allows them to. They won't necessarily be reasoning about the consequences of, you know, following only the law. Then we talk about the egoists who are very caught up in me and mine and my journey and my destination, my convenience. And people start uncomfortably recognizing themselves in that. And that particularly is the private car drivers. You know, the mom with the SUV rushing her child to an extramural, for instance, can be very egoistical in their reasoning. Then we talk about utilitarianism, which is kind of about the greater good. So if we use utilitarian reasoning, we should potentially give way to minibus taxis with 16 people plus in them if we're a single occupant of a vehicle. And that throws on its head a lot of the finger pointing at minibus taxi drivers for, you know, the way they drive, and they are the cause of the problem. And then we also talk about communitarianism, or what I like to call Ubuntu ethics in an African context, which is really, you know, I'm a person because you're a person. We're all users of the same space. It's about a negotiation. It's about a recognition of your humanity through my behavior and my humanity through your behavior. And we find in 10 minutes, we can start to shift paradigms. We also talk about moral development, and we talk about moral toddlerhood, moral adolescence, and moral grown-ups. And only about 15% of people arguably ever reach the level of moral grown-ups where they can think beyond themselves to the greater system and the greater good. And we find ourselves challenging people like fleet managers. Have you put moral teenagers in charge of your trucks, for instance? And they sometimes then go back to their drivers and they present these concepts that, you know, it's if you're not morally developed to a certain level, then you can be potentially horrifically dangerous to yourself and to other people, and of course to the assets of the company. And therefore, one of the things we need to do is a bit of ethical development or moral development. So that's some of the tricks that we use to bring about change.
Wow, holding people accountable. I think that's a good one.
Yeah.
I don't know
That's
which
great.
politicians would be moral adults, but maybe that's a topic for
Yeah.
another time.
Yeah,
I'm just looking through to see if there are any other questions, and if not, maybe to give Richard and then Heike any final last words, and then just finally see if Keith wants to say anything about the rest of the CUGH program. So who did I say I was going to start with? Richard, I'll pick on you, and then Heike.
Okay, no, I don't think I have too much to add. It's been I've said my piece, and it's been interesting getting the different perspectives. The one maybe the final aspect that we didn't delve into in much detail, the silos that stop us doing the work that needs to happen. You know, the data that we sift through is coming from health. The people in doing enforcement are provincial authorities. There's the civil engineers make the roads. I don't think there's a coherent perspective around road safety and mobility across all of those sectors and in all of those silos, and they often compete with one another. And then, of course, you've got the alcohol industry and the vehicle manufacturers and all of these commercial stakeholders. So that complexity often makes things unwieldy in terms of what the priorities and solutions are, and it also makes road safety advocates vulnerable to competing priorities. And I think that if there's a role for government in the road safety space, it needs to first understand the conceptual approaches, apply them stringently, and others need to adapt rather than be swayed by the various interest groups. But I think the conceptual understanding isn't quite there yet either. So it's an enormous amount of work we have to do to change things. Yeah,
and it would be great if the politicians could work across the silos, set priorities,
absolutely,
and kind of herd the cats, if you will. But unfortunately, they sometimes are the ones most influenced by special interest groups, specific industries. So
we had a very withering experience where we collected a lot of money to do an evidence-based intervention around speed and alcohol that would be informed by a whole very intensive data collection effort, and we convinced the Treasury to assign a large amount of funding to bankroll this intersectoral project. But when it landed with the department in charge, they quickly cancelled it and invested in a fleet of fast new cars because that's what they were used to doing. So my appetite for this work has shrunk a bit because the different groups are so invested in the solutions that they're used to rolling out with little effect. So yeah, some real big picture challenges to try and sway people's mindsets to make inroads. I think that's the biggest challenge. Over.
Heike?
I think with this conversation has really helped me to kind of think about what the next step is and how I see my own engagement, and I think hopefully all of you are thinking about the same, but also what are the next steps that we take it from here? Because as Richard says, it's going to need this massive mind shift. And it's wonderful to hear that people are working in the space, but we have the potential now to use this as a stepping stone and actually raise the priority of road traffic crashes with, I would like to say, almost with a global health lens, focused on equity, but also on a particular solution-focused lens. Because everything is quite fragmented. I think we have a possibility here. So I'm feeling inspired, and I'd be very interested to hear how CUGH and all these people that we have are able to push a particular advocacy role in that bringing everyone together, focusing on that paradigm shift, and then prioritizing the interventions and giving people a bit more of an operational sort of impact-driven framework of action, because otherwise it's not the standardized sort of solutions that we're looking at. But we do need to have a common language and a common paradigm for describing this. So I'm excited. I'm going to stop there. Thanks, Catherine.
Yeah. So Keith, I don't know if you heard, but the gauntlet has been thrown down to see what groups like CUGH will do about awareness around road traffic crashes. And I know that CUGH has taken obviously a big interest in road traffic crashes, and we're the ones who encourage us to put this panel together. So I guess in conclusion, it is doom and gloom, but it isn't in some way. Obviously, there is global awareness around road traffic crashes. It obviously is a huge burden of death and disability worldwide. I think the WHO has taken an interest being the leading health agency. I think the real question is how much impact do reports and suggestions that they make to at each country level, how much does that translate into changes in policy and specifically reduction in death? We talked about kind of the overall plan now for 2021 to 2030, and to see what happens in this decade of action to now try to reduce mortality in half. We talked about a lot of very specific bespoke interventions for different contexts. I think we talked a little bit about the conundrum of an upper middle income country with excellent roads, but still with perhaps poor legislation, poor alcohol laws, and pedestrians still wandering around on those roads, which makes for higher fatalities, I think, than places that have lower sort of speeds and poor roads. And we talked about the issue of equity, and I think that's a big one. How do we make this an important enough issue? And Richard, I think you brought up the importance of breaking down silos. I think it's great that Lee and the Alliance of NGOs is on thinking about it from an ethical and moral perspective. It is a really great one as well. And I just encourage CUGH to keep pushing in this space and maybe try to work with all these groups. I think the whole concept of global health really is to try to transcend being a civil engineer, a clinician, a data scientist, and looking at it from the whole system lens. And then maybe just to end on the note that CUGH has other virtual satellite sessions going on this week. They're also free. There was one on AfriHealth, or CUGH and African Global Health Capacity Building, on Wednesday that I'm also involved with, same time, if that's interesting to anyone. And then if any of you are based in the US, the CUGH annual conference is in Washington, DC next week. And then I'll just see if Keith Martin is still on, if he wants to say anything else. Keith, are you still here? He might have gone off. Okay, and then I think I will wrap it up. And then I see that Richard has put in some other resources. Did you put in the 2018 global report on road safety there? I think there's going to be a 2023 report as well, Richard, but I think you put in the 2018
That wasn't me,
one.
I don't think.
Oh, okay.
That was Heike.
There's a request for West African data. So I
encourage
encourage everyone to find their country and be amazed and slightly depressed, but then inspired to do some good work.
Yes, I think this panel is very based and biased towards Southern Africa, but obviously road traffic crashes happen elsewhere. There is a request to share the slides. I think maybe we can do that through Jenna, if the two of you are okay with that, and I'll ask the online panelists, but otherwise I'll give them to Jenna. Yeah, great. Well, thank you very much, everyone, and happy Monday to you, and enjoy the rest of your week, and be safe on the roads.
Great, thank you. It's rush hour, so I'll have to drive slowly. Thanks for organizing this.
Thank you.
Thank you, everyone.
Bye-bye.
Bye.